So what we're going to do is we're going to try and within limited time and under pressure, you guys know how that feels, we're going to try and create a space and a little bit of time for real conversations. So I'm going to talk for 5 minutes, no more. Then Sibylla is going to talk, Trevor is going to talk, and I'm going to talk to that table, and you'll see how this works. The purpose of the session is to reflect, to think about what you can do, because our challenge and question to you is what one thing can you do in your organization to improve, to take the next step in involving patients as partners in improvement work. If you're bringing them in to tell stories, keep them in the room. If you're bringing people in as representatives, think about them being patient partners and part of solutions. If you're doing it in one pathway, why don't you do it in two? If you're not doing it in STPs yet, why aren't you doing it in STPs? We'd like to push you on a bit from your good practice as you are, and to make it really real. So what we're going to do in a minute is you're going to have a 10-minute story, not a sob story about how it has felt to be on the receiving end of care and treatment, to give you that compassion rush and then you go away and integrate it yourselves, but what it feels like to be somebody who's had a life-changing illness, injury or disability, and to come into a room full of strangers, full of powerful professionals, and start talking about improvement as real partners and what support you need to provide us with and what we can contribute to you to make this a real conversation, human to human, where we helped you to reframe problems, come up with solutions, and develop things together. Because that's what we're about. We're about helping you and you helping us, working together. It's time for collaborative leadership, but we find that often engagement structures mitigate against that happening, and we'll be talking about that as well. So what you'll hear is the story, and then what we'll do till the end is just have conversations. We're not going to have death by feedback. So the conversation you have in your corners will be the conversation that takes you through to lunch. Okay? And how that's going to work, I'll tell you in a minute. Very, very briefly, if Ali had been here, she would have talked about what true co-production is. And if you don't follow her on Twitter, make sure you do. Alison Cameron, she's wonderful. What we've learned together as patient partners doing this very lonely work, because we're outsiders, we break into the system, it's very hard work, it's very challenging, it triggers us back, we have relapses, we don't get paid, we don't get trained, we might get a stale sandwich every now and again from a focus group, but it's difficult emotional labor. What we're asking of the healthcare system is to learn to value what people like us bring. What we can offer from those caves of suffering. What are the jewels of wisdom and insight we bring back? Not just our story of experience, but the whole thing. What's that insight we bring about being vulnerable human beings? And I know that some of you have had life-changing illness experiences as well. Some of you are, quote, patients. However, there's something a little bit fresh about bringing outsiders into the mix as part of that jigsaw. Not that we know best, not that you know best, it's about how we bring that together. We would like to ask you to change how engagement is done, to move from focus groups and feedback work, from stories where we give you and you decide what to do with our data, to collaborating together, and stop just plonking a tame or angry representative on your committees and start moving towards partnership so you change how engagement is done. We'd like you to think about investing in the skills. Leadership Academy has millions and millions and millions of pounds invested in capabilities. We have zilch. 4, we'd like you to think about new opportunities and new roles for patients. I am the first of 2 patient directors in this country with Sussex Musculoskeletal Partnership. I am on the executive team creating space for these sorts of conversations, bringing the patient experience work, the self-management work, the involvement work, and some of the comms work together. What about that? What about having a patient director? What about people coming in as entrepreneurs, as peer support workers, as all sorts of things? So we're asking you to think about a change and a step up in terms of patient partners as improvement. Because my guess is you know a lot about this and you're doing it somewhere in your organisation, and we want to ask you what the next step is. So what's going to happen in 2 minutes is I'm going to stop talking, although you'll get me again, I'm sorry to say, is what you're going to do is listen. So one of the primary requisites of any shared decision making is to listen. And you'll get a story of what works, what gets in the way, our stories of what it has felt like to be involved, to be put at the centre. It's not easy. Listen, ask questions for clarity. What did you mean? When did that happen? The facts. Be conscious of your own assumptions. Oh, he's educated. What about black people? Oh, he's middle class. What about that? Oh, that's just his story. Just be aware of the chatter, good and bad, that's going on in your head, and just hold it. Because we're talking a lot about our own assumptions, our own interpretations, and our own lens through which we see things. Listen again. And what we're going to say is this is the start of the conversation. So Trevor, Sibylla and myself, when we've stopped telling our story, we'll ask some particular questions and we'll just have a conversation. That's all we want. Nothing flash. No death by feedback. We're going to ignore glisser. Trevor knows about that stuff. And we're just going to get on with that. Is that clear about what the process will be? Is that all right? The challenge will be noise. The main thing we're going to have is noise. So if you're listening to Trevor, it might be worth, because I'm going to sit just behind you, so you're probably going to hear me rather than Trevor. For you three, you might want to choose. Maybe you could maybe one or two of you could go here and just spread to either there. Because we were going to have 4 speakers, but we've only got 3 to 3 tables, and that would be helpful. Yes? Let me rewind to 1987 to 1993. So I had a major nervous breakdown when I was 25 for various reasons. A form of OCD, form of anxiety. They never quite got to what it was. And one of the conversations, it was hell. We don't need to talk about my experience. It was just blind hell. But when I was recovering, one of the things that my wonderful doctor said to me was, David, you used to write, you used to be a campaigner, you used to do all this stuff on research into pharmaceuticals, funnily enough. I'd done research on all things that I subsequently consumed. And he said, so what matters to you? He said, and I said, I want to work. It wasn't about safe, but I want to work. I've lost all my confidence. And he said, I think you can help me. And he took me to Knapsbury Hospital, an old Victorian asylum, which was in the throes of being cut down and created into residential apartments. A place that I was terrified of languishing in forever. The nightmare place it would have been for me. And he said, I'm running a course, a pharmacology course for junior doctors. Can you come and help me deliver it? So I walked into Knapsbury, delivered a lecture, walked in as a patient and came out as a professional and human being. And that was the sort of dialogue, that was the sort of, they talk about what matters. And it was a real what matters, because he was able to do something about it. And what he did was then gave me confidence to go back into my life as it was. I wanted to go back into being an activist, a campaigner. I was more angry than I'd been when I went in. And all I could find of ways of giving my voice, I wanted to run a self-help group. I had ideas on peer support. I had ideas on advocacy. And all I could do was join a focus group. All that was available for me was join a focus group. And I went along to a few focus groups. And then they suddenly said, oh, do you want to be a rep on a committee? So I wore my Mind in Barnet t-shirt and I went to Barnet Health Authority for a meeting. And during that meeting, so I thought I was there. I was with people like you, and that's quite scary because this reminds me, this is triggering me to my discharge planning meeting. You're reminding me of the psychiatrist, my mum, you know. It's quite intimidating. So you walk in as a rep, with the Mind t-shirt, no idea what your role is, no support. You get the board papers on the Friday and it's on Monday. You haven't got a clue what the acronyms stand for. And then somebody leaned into, and my psychiatrist was there, which I hadn't been warned about on this committee. That wasn't easy, although he was great. And they leaned in and said, so David, what do patients think? So what would you say? How would you answer that question? What do patients think? Tricky. So what did I do? I told a story. So what do you think happened when I told my story at a strategic meeting? Because? When they're there,
There's a disconnect from where the information comes from to what's in the papers.
Yeah.
Wasn't on the agenda.
Wasn't on the agenda. Certainly wasn't on the agenda. No. What else? Some of them loved it. You know, some of them leaned in saying, telling it like it is. But the others said, who the fuck does he represent? You know, he's got an axe to grind. Not a great metaphor to use for mental health patients. Usual suspects. Da 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 da. So half of them leaned in saying, that's the role. Bringing it back to what matters, yeah? And half of them were saying, who does he think he is? Who does he represent? So I went back and I learned to wear a shirt and tie, and I did a bit of data gathering, and I brought the evidence back, and I came back with my suit. Imagine me in a tie, short hair. Said, there's the evidence. So what do you think they did then?
And I know what to look for and what to challenge.
Yes, he's gone native. He's gone native. It's not independent. So you can't win. You either know too little or too much. It's a beautiful catch-22 for the representative. And what I've noticed over 30 years, 20 years of doing patient and public involvement work is that is how the engagement industry on the whole works. It's either you give me feedback on your experience of services, not in your life, not in your work, the service. Would you recommend this psychiatric unit to your friends and family? Well, the fact that they never visited me was part of the problem. I probably don't think they would want to have come. And there's this feedback child-parent mode. We give you information, you analyse it through your own interpretation of what's feasible to improve, because you know the systems might not. But there's an interpretation through the institutional lens, and it's child-parent. I give you all my data, I give you everything, I disclose everything, you deal with it. And it's very, very redolent of care and treatment. Or you stick me on a committee, we need a rep. One of my friends said he's sick and tired of becoming the lay rep pimp. Find me a rep for the committee, and bunging them on. And that becomes adolescent, because what do I do when I'm ignored at a table? What do you do? Yeah, always, you can't hack it. That psychiatric patient has gone angry again. You're buggered. So it's a caricature. Yes, it's a caricature, but that's how I've seen that engagement doesn't work. It's not fit for purpose. So here you come along, wanting, I'm assuming, to work with us, that we bring something, you bring something, we work together, we think what the problem is, and we come up with solutions together. And that's QI, isn't it? I mean, I don't know, PDSA means people's dispensary for sick animals to me. But you get together in a gang, you decide what to do, and then you go and do it, yeah? And you need people in the room like me to see whether this project is about the waiting room and access, or it's about transport. And I can help you reframe that to be a wider thing, or I can help you ask questions. We're all needed. So I think engagement is not fit for purpose, and what we're discovering is there's people like Trevor, people like me, hundreds of us who are battling to get into these conversations because we're tired of the them and us. We're really tired of it. We don't want to be angry anymore. We want to work with you, and there's some excellent work happening. I'm sure, who's doing experience-based co-design? Yeah. Also co-production stuff in the community. Yeah. I mean, you're doing it. It's wonderful when it works, when you got the right mix. Something happens. I don't know. Let's talk about it in a minute. But it's not happening in STPs. It's not. It's happening where there's a good clinical lead and a good project manager and a couple of good people who give it a go because they've got a relationship with their patients and they know these people have also got drawing on their lives. They might be graphic designers who can help you do stuff. They get it. But the professionals in the room probably get it. And
that's what I mean, the professionals, it's kind of choosing your champions, pushing on an open door.
Exactly. So there's a start. And my job now as patient director is to create those conversations wherever we can. So what we're doing is that we're creating a bank of patient partners, a bit like people like us, who can be involved first in improvement conversations, because that's where people get it, so they go into a friendly environment. And now we want them to step up into multidisciplinary teams and governance, and that's quite tricky. So that's our next step, because the support needed to go into a meeting with an orthopedic surgeon is different from our wonderful specialist rheumatologist. So I think I was going to tell a story of what happens when people are in the room, but actually my guess is you have your own stories of what can happen, so I'm going to leave that to you. So my question to you, and I'm going to put it up, I'm going to leap up on the slide, is
So we've got money to try and fix it.
what's going to help and what's the question here? Okay, two questions. What have you heard? What struck you about what I've said? It's rubbish, I'm doing it already, or there's something there, I want to ask a question. Just in pairs. What have you heard? What struck you? What do you want to ask? Just in pairs. And then let's come back into a group and just have a conversation about what one thing might you change to step it up. If you're doing it in diabetes, how might you do it somewhere else? If you're doing it in improvement, how might you... if you've got somebody in the room doing stories and staying in the room, is there a step for that person or a group of people to come into the advisory group or step up to a corporate level? How do you move? So just what's that change, just that one step you do to take further? And there may be some questions you've got. What is a patient partner? What is a patient leader? What do these words mean? So there might be questions as well. Yeah? And
what I found really struck home with me from what you were describing was that getting the papers on a Friday afternoon, expected to use my downtime to read them for no training or support around how to conduct yourself in business meetings. And we were just saying actually that lived experience by itself isn't enough to guarantee you a space at any kind of table. It's about developing skills, and so having role descriptions for people is really important. Co-produced role descriptions.
We've got one if you want to borrow one in Sussex.
Oh yeah, we've got
Oh, you got it.
Yeah,
Maybe I'll borrow yours.
Yeah, maybe. But also paying people is really important. Not everybody who uses services, whether they're mental health services or acute hospitals, is on benefits, and actually, getting paid for things like this is important. It's not a want, it's a need. So a lot of what you were saying was and also that, I think I was chosen initially because I've never been a passive recipient of anything, but the danger is that your voice doesn't represent the users of the organisation. So it's about, for me, how it's a bit like being an MP. You have to go out and talk to people that do use services. A bit like being a governor.
Yeah, I think I'm becoming a door opener rather than the person who stands in the door.
Yeah.
So I think there are three things that come up. Hang on. So what I'm hearing is that there's something about valuing people and whether valuing includes payment. There's a question about skills and investment skills, and there's also a question about recruitment and inclusivity and who is doing this work.
And that was something that you touched on as well that I found really important. The 20 years that I've been working with my local mental health trust, they've never been able to produce a kind of a document or resource of lots of different service users who want to get involved in different areas, because we were saying it's not just about sharing your lived experience about what it was like to live on the ward or whatever it was. You know, you're going to have people with experience in finance, estates, business. It's not.
So you're bringing all of you.
Bring them. But I also work in the University of East Anglia, and the way that we're making sure that experts by experience are embedded in everything that we do there, from teaching to module planning to admissions to interviewing students. We've created a database that the different schools can use. Yeah, so it's got the patient's name, it's got their condition, it's got the areas that they're interested in participating in, and you can access that as a lecturer.
So it's about creating
It's about
opportunities.
building that database, providing opportunities, but also training packages.
And training. So there's training and skills, there's knowledge and opportunities, there's recruitment and who's around the table, there's valuing people. Tell us who you are, because I recognise your face.
From Northumberland Town and Weir, FFT, which is a mental health.
Do you know Annie Laverty? Do you know Annie Laverty? The Healthcare Trust, it doesn't matter.
I guess I'm really struck by the whole, what you were saying, and I think what you've been saying as well, around that whole idea of being a patient representative. And always being a patient representative is a very difficult place to be. Because what is a patient? You know, we're all patients, we're all carers at some point. So how can you represent broad views? I think that bit you said about being someone who opens doors, because the key thing is, how do we actually spread this so it's much broader and wider than being the patient representative who comes along.
I'd like to destroy the notion of representative.
It
I'd
doesn't
like
work.
to kill it.
It doesn't work. You need to have.
So I think now, sorry, go on.
So it's about embedding that across the whole organisation, from those decisions at a personal level around your own care, around decisions around how a service operates, right at the very beginning. How do you get real, true engagement? I really like that idea of having that database of people who would be interested in the conversation.
And you could do that with the skills order. You do it with staff.
Having that. Are you prepared to have the conversation? That opens the doors, doesn't it? Even just on that.
And I think now that if somebody asked me, so David, what do patients think? I'd say, why don't we find out? And maybe I can help you do that with some of my links, but I'm there maybe to challenge some assumptions and ask questions.
I guess the other thing I'd say, is it is hugely subversive because we are institutionalised to do to people, and this is about absolutely fundamentally turning that on its head.
And what is nice about it is my clinical leads love it because they're up for it, and this is why they joined the service, and they don't want to do the focus groups and the FFT anymore. They want it real as well. So, and they've got difficult solutions. My question to you is, why aren't we involved in STPs? My question is why I know all medics and local care, everyone's been shut out.
I think it's Lorraine Fox, Head of Safeguarding Children. So we were from Head of Safeguarding Children I manage Safeguarding Children Services in North Yorkshire. So we talked a lot about engaging children and young people, and actually we found that the children and young people who sit on our forums all want to be doctors or nurses, so it's maybe not a true representation of the population who we serve. So it's how do we engage others, and how do we do that, having the right governance around, I think my passion...
So the governance is around confidentiality as well?
Not about confidentiality, but we've been quite open with our young people, and we've taken them through ED with maybe some very minor illnesses that they didn't have, just to actually understand what their experience was, but actually were criticised for not having the governance probably in place better. So we had it very much in place for the young people,
so some
really
of the
clear parameters about
logistics.
what can and what cannot happen. From a governance perspective, they wanted more people to be aware, and we're saying, well, if they're aware, the experience might not be how you want it to be. So it's getting that true life experience for them that informs how you practice with the governance right, if that makes sense.
So I think one way of doing it, is to have some partners who are in, people like me and Kevin, or some really good adolescents. So, you know, you pick them and you open up that role description, they become the door openers. But the actual representation bit, I mean, many of you got research skills. You know how to do qualitative research, you know how to gather data. And it might be through other surveys, you bring the data into the room and you get different eyes on it. So these people are not necessarily the people who go out and run the focus groups, because that's bloody tiring as well. And you're free resource. So you've got involvement leads to do that for you. So I think there are particular challenges, like people say in emergency departments, in end-of-life care, in children, young people, learning disabilities. But you've got good practice all over the country in all those groups. People have cracked it, I think.
Another thing I talked about was maybe having yourselves leading the meetings rather than you being on a meeting.
Yeah.
Co-chairs, lots of people do co-chairs.
Why would you not? Because it puts you right at the front. Then
So
if
the
you
mental
led
health trust that I'm embedded in, so adult recovery and central acute, the business meeting, the governance meeting, the senior managers meeting, I co-chair those meetings with a staff member, so the service managers, and it just reinforces the message to staff that we're partners together and we're co-producing from the word go.
Do you think mental health's in the lead a bit? A bit? Maybe I'm biased.
I think it's down to who works in your mental health trust. I think who your champions are. Work with the willing, I think is probably the best way to go. But I'd probably say the work that I'm doing at the university is probably more creative and innovative.
Interesting. Why do you think that is?
Because it's less risk averse, it's less data. I'm kind of thinking, why 20 years of working with mental health trust we've not been able to create a database, and yet 2 years of working embedded in the School of Medicine at UEA. We have to protect data, but it's not, it's a bit like the voluntary and third sector can do really creative, innovative things because the governance structures aren't as strong and constrained, they're not constrained so much.
So there's something for me about where you start. Improvement, experience-based design is one place. So if people are lacking in confidence, where they can come in to tell their story and where that's a legitimate thing to do, and they say, well, you've told your story in the training, education, or in research, or in improvement, stay in the room. Stay in the room. Take part in this. We're not going to kick you out. But there's something about where people start, where you get that, because that's where you do lean on your experiences, and slowly you're able to use your stories more judiciously. You bring them in as questions, or you come in and say, well, this is me. I'm aware that this is just about the environment. My story is just about this, and there's all this. And your data says this, what are you doing about that? So you've moved from
I'll give you an example where it really works really well. When you say, what is it different about mental health services? I've been leading on a recovery project for the last 7 years, and that's about having peer support workers in the workforce. So we co-designed, co-wrote with staff members a 12-week training course for people who've lived experience to work in clinical settings and utilising their everyday lived experience and applying that to the teams that they worked in. And that was quite tricky because, a lot of people were saying, oh, it's a cheaper version of having nurses, or you're going to get rid of all of these staff members. But it was about utilising lived experience and professionalism to enhance the team dynamic. And one of the things I think could work well with other organisations that works within mental health trusts is recovery colleges. So, college courses, you learn in an educational setting. The courses are co-written between service users and staff and or carers, and they're taught by staff and service users, and you're all learning together, and we make sure everyone takes off their lanyards, and you can't tell the difference between, unless you know them personally, who's the service user, who's the carer, who's the staff member. And I think that's where you can deliver the training packages around how to chair meetings or how to support people in, so I think that's a good
So a lot of opportunities, research, education, peer support. Anybody else want to say something? We've only got 5 minutes, inevitably time. Is there any burning question, burning issue, something different? And say who you are.
Oh, sorry. So I'm Ursula. I'm from the Birmingham Women's and
And what was your
Children's.
name?
Ursula Houston. something about, I guess, we were talking about like almost like where does the power sit in different settings, and so if we're working with children, how can we make them feel more, I suppose, like comfortable to contribute? And well, what I was going to say kind of was that I wonder sometimes if is it taking into account different forms of power? So it might be that you're a patient rep, but in some situations you might be more powerful, I guess, like. Say that again.
Can we call them partners rather than reps?
Sorry, partners. Yeah, sure. And I suppose, like on the one hand, it's. I suppose what I'm trying to say is it taking into account that who is it who becomes a patient partner? Like how do you include everyone? And I mean, yeah, I guess that's what I was trying to say.
So there's the power of the position of being the patient partner, is what you're saying. Not you, because what I thought you were going to say is about professional power, but you were saying something slightly different.
I think there is professional power, but then also who is confident and educated enough to become a patient partner.
So I think for me, you start where you can. And what we're doing, for instance, in Sussex is we're very aware that 6 of the 8 are women, all of them are middle class, and now I've got a meeting with them on the 17th to talk about recruitment and diversity and inclusion. Not that we want, one black, one white, one girl, one boy, one trans, one non, but it's about getting a good enough diversity. But then for me, it's about clarity of the role. So it's about those people knowing who's not in the room and those people being able to challenge. So we do work in Crawley, but many of our patient partners are based in Brighton. So there's something about providing them with inclusion and diversity data so that they become the people who provoke those questions. So we're doing it in Brighton. What can we do in Crawley? What are the community groups you got there? So there's that inclusion, diversity, understanding and awareness, and a gradual broadening to a much wider recruitment pool. And can I just, before you, and then come back to you, is I think this is all good stuff that staff should have as well. It's really amazing how the spotlight is always on the patient advisor, patient partner, patient leader, and there's no real, we have to be whiter than white, sorry for the pun, but it's about, I think, what we bring in is a bit of rigor around that role, clarity of role, and then also, do other people know how to be a partner in the room? Does the physio know when to shut up? So, and you were going to say, sorry.
I was just going to build on what Ursula was saying about that, the type of people that become patient partners. You said earlier that it's the consultant might have a good rapport with that patient, and that person becomes a patient partner. Some of the most vulnerable people in the community would be people that would not even want to go see their GPs. So I suppose as the NHS and social service, what are we doing to go into those communities where people don't want to engage with healthcare services to say, look, we're not scary? Because even inviting people into our territory, if you like, is quite intimidating, and we can build watering holes for them, we can build platforms and social platforms and stuff for them, but if that's not what they normally use, if that's unfamiliar for them, should it be better that we go to where they're familiar and where they're comfortable and meet them in their place of comfort, and we be the guests, the visitors? I think
that works on, for me, that works on 2 levels. One is when you're doing the engagement work, when you're doing the real experience-based design and the QI work, when you're getting that conversations going about what it means to be using service, what it means to be providing, and at the patient partner level, those people who are involved at the more strategic level. We did something with, I think it was Hackney CCG a long time ago, and they had a really good group, and the decision was made that where they developed their network had to move from the CCG offices back into some community groups. So I think it works on both levels. So I love that idea of who's the host and who's the guest. So hang on a sec.
My name is Sophia. I'm a care navigator with Central London Community Healthcare. I just wanted to build on what you were saying. So those patients are afraid to go to the GPs. I do a lot of social prescribing, so that's where that comes in. So what we tend to do is we get referrals from GPs that haven't seen some of their patients for over a year or 6 months. So we tend to go to their houses because we do home visits and then we find out what's going on with the patient. So we try to navigate the patient back out of that isolation and that loneliness, try to get them into into the community and trying to find out and help them take control and take charge of, you know, what's going on around them and their health as well. So that's another way we try.
And I want to talk to you because we're trying that in musculoskeletal services, and what we want to do is train peer support workers to do that work.
Yeah.
So you're widening the team so the people become, so you're co-producing the offer as well. It's a lovely model because that's where you can really get the role right and where you can do something that's more than just the conversations, it's a bit of doing as well. Thank you, it's been really short. Do come and find us, everyone knows where we are. So thank you very much.
Thank you.
Sorry, it's short and sweet. Well, short and whatever.
Yes, I will do. I'll definitely be in touch. Thank you. Even if